Hi, I'm Krishna Komanduri. I'm the Julius R. Crevens Distinguished Professor of Medicine at UCSF, and I'm Chief of Hematology and Oncology and Physician-in-Chief of the Helen Diller Family Comprehensive Cancer Center at the University of California, San Francisco. It's a pleasure to be here today, and I wanted to address a couple of questions that were really critical in the area of lymphomas and emerging therapies. The first thing I want to talk about was CAR T cells, and I think that one of the critical advances in CAR T cells and the developments over the last couple of years has been the understanding that two of the three CAR T cell products that are approved in the treatment of relapsed and refractory third-line lymphoma have now been the subject of pivotal trials that led to significantly better outcomes in patients with high-risk or early relapsed lymphoma, that is second-line lymphoma. So two of these products have now shown benefit in second-line lymphoma. And in the past, when somebody relapsed after initial attempts at curative therapy for lymphoma, they would be treated with salvage chemotherapy. And if they responded to salvage chemotherapy, they would go to high-dose chemotherapy and autologous stem cell transplant. But now, rather than moving directly to salvage therapy and autologous stem cell transplant, trials of CAR T cell therapy at the point of early relapse have demonstrated superiority over that approach. And why is that? It's in part because of the lack of efficacy of salvage therapies in effectively getting patients to auto-transplant. So less than 40% of patients in those trials actually went to the auto-transplant. And patients who received CAR T cell therapies have had significantly better progression-free survival and overall survival. So that's really been very exciting. One of the other important advances in lymphoma therapy in the last year have been a number of trials that are showing increasing success and promise of what we call bispecific antibodies. So bispecific antibodies have two domains, one that recognizes a target on a cancer cell, and the second that recognizes a T cell. So they effectively bring patients' own T cells in proximity with cancer cells that can then allow them to act just like a genetically modified CAR T cells can. And we have very promising data. There was a pivotal trial of mosunetuzumab in patients who had relapsed and refractory follicular lymphoma that was positive, met its primary endpoint, and led to an FDA approval in December of mosunetuzumab for relapsed and refractory follicular lymphoma. And more recently, a trial of glofitamab, which is a potential pivotal trial, demonstrated benefit in patients who had highly refractory relapsed non-Hodgkin's lymphoma. And in fact, a third of these patients had failed prior CAR T cell therapies, and this led to excellent progression-free and overall survival. Finally, one of the things that we have to think about as we think about these therapies, whether they're bispecific antibody therapies or CAR T cell therapies, is how well we're doing at actually getting them to the patients who need them. And there, unfortunately, there I think is both good news. The number of patients receiving CAR T cell therapies is increasing, but unfortunately, it's not actually allowing us to address the need that actually exists. So if you look at CAR T cell therapies, for example, for the third-line indications in relapsed and refractory diffuse large B-cell lymphoma, probably only about 30% of patients who should be getting these therapies are getting them right now. And then when we look at patients who have historically been the subject of access barriers, for example, patients with lower socioeconomic status, patients who are underrepresented minorities, or others, we see actually greater barriers. And I think this is a really important problem that we need to address. And I think all of us need to think about access and equity and the financial value of these therapies, and making sure that we can not only deliver therapies to patients who are in trials and have great needs. So these therapies are transformative, bispecific antibodies and CAR T cells, but we also need to make sure that we do the best possible job of making sure that patients are referred for therapy, that they can afford those therapies, and that they actually receive life-threatening and potentially transformative therapies.